Hello, and thank you for taking a few minutes to listen to this Take 10 talk about establishing a phototherapy clinic presented by the International Psoriasis Council. My name is Colby Evans. I am a dermatologist from Austin, Texas, and the past board chair of the National Psoriasis Foundation here in the USA. In terms of disclosure, I have done work for Celgene, Novartis, and Pfizer, but have no conflicts with any phototherapy or laser manufacturers. If you're considering starting a phototherapy clinic, one of the challenges can be just deciding what type of phototherapy to offer because there are so many different choices nowadays. I would suggest you begin with narrowband UVB ultraviolet B phototherapy, which is sometimes called TLO1. It's 311 nanometer wavelength, is very versatile. You can treat a variety of conditions, including very common conditions like psoriasis and vitiligo, and it is often more forgiving than other treatments like PUVA. If you have success with narrowband UVB and you wanted to consider what to have next, a 308 nanometer excimer laser can be very helpful for thick plaques of psoriasis or for vitiligo on the hands and feet, for scalp psoriasis, or resistant plaques of psoriasis where other treatments have largely improved the patient, but they have those persistent plaques on the hands or elbows or knees. And a hand-foot narrowband UVB unit can also target obviously the hands and feet as well, more specifically if that's just where the patient has disease. And then if you're in an academic center or a specialized center, you could consider more advanced phototherapy choices like PUVA, which is seeing less and less use as an oral therapy over the years, but is still sometimes used systemically or used in a topical or bath preparation. UVA1, which can be used for skin hardening diseases like morphea, and broadband UVB, which is probably less effective for psoriasis, but may be more effective for a few things like systemic itching. I'm sometimes asked, why start a phototherapy clinic at all given all of the new treatments that are available, especially for psoriasis, over the last 20 years? And there are a variety of good answers to that question, but I think the first and most important one is safety. Phototherapy, especially narrowband UVB, is very safe and can be used in a wide variety of patient populations where systemic agents may be more difficult, like patients with cancer, immunosuppressed patients, patients with severe comorbidities, even pregnant patients and children can safely use narrowband UVB. There also are patient concerns about safety. Although many of the new biologic agents do have favorable safety profiles, it certainly can be worrisome to a patient who's never taken an injection before, and phototherapy is an option that has that broader safety profile. Cost and availability of biologics obviously can be a significant problem the world over. So even if we have treatments that could really help the patient, if they're not available or they're not affordable, something like phototherapy may be a better initial choice because its relative cost is minor compared to the cost of biologics. It also can be used as an adjunct therapy. Phototherapy can be added on to biologic or other systemic therapy when that therapy is not getting the job completely done. There are also conditions that, at least in the United States, do not have approved therapies where phototherapy can be quite helpful, like granuloma annulare, of course, vitiligo, and other common dermatologic conditions that may not have a specific therapy approved. And then lastly, as I mentioned, special populations, children, pregnant patients, the immunosuppressed, the elderly, can all safely benefit from narrowband UVB especially. This article makes for a good read if you are interested in optimizing phototherapy for any given patient within your protocol, particularly narrowband UVB. They found in their meta-analysis that twice-a-week therapy and 3-time-a-week therapy both do work, but you see faster results with 3 times a week therapy, 88 days versus 58 days to clearance. It does help to have the patient thinly apply petrolatum to their plaques of psoriasis to increase transmission and decrease the reflectance from the scale. And in this meta-analysis, 62 to 70% of patients with narrowband UVB did achieve a 75% improvement in their psoriasis area and severity index score. They also looked at a randomized trial that showed narrowband UVB was approximately similar to PUVA for achieving PASI 75, although it was slower, and PUVA achieved that PASI 75 more quickly. Nowadays, PUVA is less common because of the systemic side effects from psoralen, so even though it is a little faster, it is less commonly used. Home treatment is quite common, especially with narrowband UVB, and can be equivalent to hospital or clinic-based therapy in terms of PASI 75 numbers with greater patient satisfaction. And of course, phototherapy can be used in combination. It is particularly synergistic with oral retinoids, but can be used with biologics and some other systemic agents as well. Lastly, I'd like to go over my recommendations and experience running a phototherapy clinic. And of course, mine is an American experience, so some of the details may be different in other parts of the world. First of all, phototherapy is a convenience-driven therapy. Patients come 2 or 3 times a week in the beginning, once a week or twice a month later on for maintenance therapy. And if they cannot park easily or get transportation easily to the phototherapy clinic, it's much more difficult for them to come regularly. The clinic hours are also very important. If the clinic opens early and is open late, they can come before their workday or over lunch or after their workday. That makes it much easier for the patient. It's important to have a hanger for their clothing. The patients will be disrobing during treatment, and so they'll need some place to put their clothes. A mirror is very helpful so the patient can fix themselves, fix their hair after treatment before they go back to work. And a fan is often quite helpful. If you look at the picture on the upper right, you can see 2 fans built into the phototherapy cabinet. It can get quite warm, especially patients who are receiving longer treatments. And of course, if for some reason treatment is not convenient to a given patient, home therapy can be an easy way to solve that problem. It's great if you can to think about your clinic setup ahead of time, to have specialized space for the phototherapy unit so that you don't have to take up a clinic room to use it. And many of these units require specialized power access installed by an electrician. You need capable staff who can follow your protocol and then can seek physician help for any unusual circumstances. So for an individual patient on routine protocol, the staff can provide the treatment by themselves, but if there were any kind of problem or major disruption to the therapy, know when to seek help from the physician to make sure the patient's getting the right dose. And it's critically important to clearly identify each patient, ideally by their full name and their date of birth, so that you do not give the wrong patient's treatment to a different patient. More frequent therapy, as we mentioned in the last slide, leads to faster improvement, and that then, in my experience, leads to better compliance because the patient is happy that they're getting better more quickly. So it's important in the beginning of therapy to tell the patient how often they're going to come, to encourage them to come as often as possible within that protocol so that they can get better more quickly. So a typical visit walkthrough might look something like this. Welcome back, Mr. Sam Jones. Could you please confirm your date of birth? The patient confirms their date of birth, so you're certain you are giving the right dose to the right patient. And it is possible to use paper slips for the patient to fill out with their name and date of birth and last treatment details if that's more convenient. Your staff might then say, I show your last treatment was 3 days ago. How did your last treatment go? Did you have any redness or burning? And the protocol will indicate to the staff member what to do in various situations, like if the patient had a lapse in treatment or if they had mild redness or burning. I find it very important for then the staff member to tell the patient what to expect while they're in the phototherapy booth. And this is very helpful so that if there is any kind of problem with the calculations, the patient has an opportunity to understand that and say something about it, or if they are in the unit longer than they expect, to come out and seek help from a staff member. So you might say something like, we're planning to treat at 780 millijoules today, which is a 20% increase from your last visit, and it should take roughly 5 minutes. This provides the patient an expectation at each visit and an opportunity to make sure that we're all in agreement about the dose. We then provide reminders in the phototherapy room that tell the patient to wear goggles at all times, use petrolatum moisturizer for treated areas, use sunscreen to protect areas that are not to be treated, like for example the face, and to cover their genitals at all times. And we found it useful to have a PowerPoint slide presentation introduction that can be used when the patient is first initiated on treatment to go over all of these things in detail, and then to again provide that on a sign inside the phototherapy booth. And then lastly, you can see the picture on the right is of the back of the door. There's a hook for the patient to hang their clothing, and then there's also an airline bathroom style lock so that the patient can feel comfortable in their privacy once they're in the booth and changing clothes. Thank you very much for your time.